Hey guys, this is a continuation of the last video. This is the last video I discussed up to clinical features. This I am just describing the prevention and management. How will if the last case occur, how we have to manage in the OT. Okay. If you are new to my channel, please subscribe my channel, guys. Okay, guys. Thank you. First, we will be seeing the prevention. Prevention. How will you have to prevent is actually you have to use of lowest effective dose possible, with local anesthetics. Okay, should be used during the intra for any peripheral nerve blocks or anything. You have to use the lowest effective dose, followed by which second is actually aspirate before. Safe injection techniques. What are the safe injection techniques? Is actually just aspirate before giving any drug into the block. Aspirate and give in incremental dosages. Don't give all the drug in single shot. Give an incremental 3 to 5 ml incremental dosage, so that the duration is getting prolonged, so the last occurrences also will get prolonged. Last occurrence is in a maximally observed in minutes. That is also there is separate is there table, I think, is there. Last occurrence is actually less than 1 minutes. Last occurrence is actually 28%, whereas between your 1 to 5 minutes last occurrence is 22%, and 5 minutes to 10 minutes occurrence is only 10%. 10 to 30 minutes occurrence is 20%. So initial last reporting is actually seen as less than 1 minute, is most probably seen is 28%, followed by 10 to 20 minutes, that is 20%. Average is 10 to 15 minutes. The clinical features will start to appear, like you will be seeing the arrhythmias and patient, and you will be seeing all the finding cardiovascular and CNS related findings. Okay, when you have to maintain the patient, don't give heavy sedation. Avoid heavy sedation when you are going to give regional anesthesia. Why they are avoiding asked to avoid heavy sedation is because the CNS symptoms the patient experiences, we can able to appreciate it better compared to the CVS toxicity. So that when the patient complains of CNS peripheral numbness, tingling or like that, then we have to take adequate precaution, and you have to stop the infusion and prepare for the last management. Which are the things needed, just I will be covering it in the management part, so I have to prepare for that. Okay, avoid heavy sedation, and when you are injecting also during the test dose, you test dose and see either ADR 1 in 2 lakhs or 1 in 4 lakhs ADR, and observe an increase. If there is intravascular injection, there will be increase in heart rate. You will observe more than 10 beats per minute, and systolic BP more than 15 millimeter of mercury you will be able to observe. So that means it is in the intravascular injection. Then reposition it and aspirate before giving any drug. And these are the major, I think, lowest effective dose, safe injection techniques, and heavy sedation. These are some of the techniques we can prevent the last. Okay, and the dosage, according to the toxic dose, that is 0.25% ropivacaine, 0.25% bupivacaine is up to maximum 2.5 without adrenaline, and with adrenaline can be used up to 3 mg per kg. The dosage part, I think there is separate class. I am going to make the dosage of local anesthetic, so yeah, and that I will cover it. Okay, so next coming to the management. If last has occurred, you observed and last has occurred, what will you do? So first, when you suspect the patient infusion or epidural is ongoing, stop the drug that is going. So epidural infusion you have connected, or something that the patient is ongoing toxicity you are observing, then symptoms are there, then stop the drug first. Next, call for help. That is most important, because you won't be able to manage alone. Call for help. Okay. Meanwhile, you have to arrange for the airway management. If the patient consciousness is everything different, airway, anything ABC, airway, everything, breathing, circulation have to be secured. Okay, airway management. And if the patient consciousness is dipping, just intubate the patient and ventilate with 100% oxygen. Why? You have to avoid hypoxia, hypercarbia and acidosis, because if it happens, it will further potentiate the action of the local anesthetics and cause myocardial depression. Already myocardial ischemia is there, it will further exacerbate that, so that you have to take action. Meanwhile, you are doing this call for help, that time itself you have to arrange for the CPP bypass, cardiopulmonary bypass in standby nearby, you have to arrange it. Because if we fail to resuscitate with the normal routine things, then we have to go for the bypass. Because call for the bypass. And another thing you have to arrange for this, if emergency is intralipid emergency airway equipment, you will arrange and intubate the patient if needed. And emergency intralipid 20% should be available inside the OT. You have to make available of them. Okay, if the patient you have intubated and is seen, and most common CNS and 25% incidence of seizures also is there. So for treating seizures, benzodiazepines should be used. Don't use propofol, because already patient hypotension will further potentiate to patient will go for asystole. Hypotension and arrest, cardiac arrest, asystole can happen. So benzodiazepines can be used, okay, for controlling the seizures. So now these are the things you are resuscitating. Meanwhile, you are managing the vitals. Meanwhile, your intralipid has arranged. Then you have to start for the intralipid. How will you start the intralipid? So intralipid, there are so many recommendations. AAGBA, ESRA most commonly used this ESRA. Other AAGBA guidelines, every guidelines is there, and AHA guidelines is there. I will just mention it separately. In ESRA, what they have mentioned is actually you have to give 100 to 150 ml bolus of intralipid 20%. Okay, over how many minutes is actually over 2 to 3 minutes. Okay, followed by you have to give 200 to 250 ml over 10 to 15 minutes. Okay, boluses. So if needed, if the cardiovascular stability is not occurred, or hemodynamic instability is there, still persists, you can repeat the bolus dose once or twice. Repeat bolus once or twice. You can give the repeat bolus doses. Okay, this is the ESRA recommendation for treating the last. Okay, next you will be seeing next another thing is, if this is actually the ESRA has recommended this for more than 70 kg. More than 70 kg people is there, you can use the bolus doses, everything. If the person is less than 70 kg, then you have to give 1.5 ml per kg bolus IV over 2 to 3 minutes, followed by you have to give 0.25 to 0.5 ml per kg bolus IV over bolus IV until hemodynamic stability is occurred, and it should be continued. If the hemodynamic stability is occurred also, you have to continue for 10 minutes. Okay, ESRA has recommended maximum dosage up to 12 ml per kg intralipid can be given. This is ESRA's recommendation, 12 ml per kg, and propofol should not be used as a rescue therapy for intralipid. It should not be used. Okay, these the ESRA guidelines. Okay, next coming to your AAGBA guidelines. AAGBA guidelines, what they have mentioned is actually bolus dose, the same thing they have mentioned, 1.5 ml per kg bolus dose, and repeat bolus once or twice. But their bolus can be repeated even less than 5 minutes also. We can repeat this 2 boluses, but here the time duration between the 2 boluses is 5 minutes. So giving another 5 minutes after that only you have to give another bolus, and maximum infusion up to 0.5 ml per kg bolus, and double the infusion can be given. In here maximum up to 0.5 only, after that there is no increase. Here double the dose of infusion. If hemodynamic instability persists, double the dose of infusion can be given in last patients. Okay, this is recommended here, and it should be continued up to 30 minutes. Whereas AHA recommends continuation of this intralipid up to 30 to 60 minutes after the hemodynamic stability have been achieved, and mostly the AAGB also recommends the same thing, bolus doses, everything, and maximum here also you can, maximum is 12 ml per kg maximum dose of intralipid, but in AHA maximum dose is 10 ml per kg. Okay, intralipid. Meanwhile, intralipid you are giving, even what intralipid is doing, just it will the mechanism of action is not still known very correctly, but what it will do is it will go and bind to the local anesthetics at the tissues, and then displace the local anesthetic from the receptor site and transfer from the and transfer to the liver and kidney for metabolism and excretion. Okay, that is intralipid usage. Okay, so these are the dosage and these are the recommendation I mentioned. If the patient is not at all responding to anything, the final option available with us is CPB. You have to take the patient in pump, and meanwhile we have to stabilize the patient, and then repeat the, you have to remove it, and then intralipid you are given, so it will displace everything, and then patient will recover slowly. You have to transfer the patient to the higher referral center. So these are the major things. Okay, what are the things I mentioned? First, when you are suspecting local anesthetic systemic toxicity, stop the drug, call for help, arrange for bypass and intralipid. And airway management, you have to intubate the patient with 100% oxygen. Hypoxia, hypercarbia, acidosis have to be reduced. And seizure management usage with benzodiazepines. And intralipid is the drug of choice, so we have to give boluses according to the recommendation I mentioned. If everything fails, then go with cardiopulmonary bypass. Is the final step. Bypass, we have to take the patient, and we have to then we have to transfer the patient to the higher referral center for further management. Okay guys, thank you for your support guys. And I want to mention that basics of mechanical ventilator, so there is so many people have asked me, and breathing system. So I am going to cover basics of ventilator in the forthcoming videos. Okay, please keep motivating me guys, just keep support me, and if you like my videos, push the thumbs up button so that it will motivate further me, so that I make more videos for you guys. Thank you guys once again.